hear me? I'm assuming yes. Yeah, good. Thanks for joining us today. We're going to really focus on how to review a patient with cardiovascular disease, particularly hypertension patients and those with heart failure. We know that we don't know everything about what structured medication reviews will look like in the DES, but the principles, the clinical principles, are the same regardless. So my name's Helen Williams. I'm a pharmacist. I've been working in South East London for about 25 years, specialising in cardiovascular, now working as a consultant pharmacist in both South and North London and with NHS England. And we've also got Rachel, who hopefully is going to appear on screen in a minute because she's muted and her camera's off. Hi, Rachel.
Hello.
Do you want to introduce yourself?
Hello, I'm Rachel. So I work across South London, looking after cardiovascular patients in South London, South East and South West London.
So I'm going to hand over to Rachel. She's going to just go through a few preliminary slides and talk through a couple of hypertension cases, and then I'm going to go on to heart failure. So over to you, Rachel. I'm going to disappear, and I'll be keeping an eye on the chat box. So if people have questions that you want me to fire at Rachel, I can do that as we go along. Over to you, Rachel.
Thank you, Helen. So we're just going to talk a little bit about what structured medication reviews are. Going to try and move the slide. So we're hoping to hear more in the next month about what the structured medication reviews are supposed to be like and some more guidance. But the aim is that from the 1st of October, we'll be doing the structured medication reviews in primary care. So if you don't know, they are a clinical review of patients' medicines and aspects of their health. So for cardiovascular patients, we're looking at their lifestyle, their adherence to medications, and trying to optimise the medicines to reduce their cardiovascular risk. There's thoughts that we'll be focusing on patients who have complex and multiple medicines as a focus group. So in cardiovascular, these will be patients with high-risk medicines such as anticoagulation, antiplatelets, patients who may be taking more than 10 medicines, and patients who are frail. So these reviews will occur by shared decision-making conversations, so involving the patient in the decisions that you're making and making sure they're happy that the medication is working well for them. PCNs will use tools to prioritise and identify these patients who may benefit, but it will depend on your capacity in your PCNs. And it's important that patients know what to expect from these medication reviews. As we're all generally working remotely, many consultations will not be face-to-face. So there's a really good article in the Pharmaceutical Journal that explains how to do remote consultations and things to consider. So the biggest part to play in these consultations is to involve the patient in any decision you're making and develop a relationship with them when you first meet them so that they feel confident to tell you how they're feeling. Make sure the technology is working and that you have all you need to make the decisions that you're making. About 40% of patients do have their own blood pressure machines, but just make sure they have them before you do the review if you want them to have a blood pressure check. Make sure you can hear each other, make sure that if the patient needs, they have carers to help them, and make sure that if the review is not going to plan and you need emergency help or you need to arrange a face-to-face, make sure that does happen. And in the review, it will be important to plan the next steps for this patient. There's talk of SMRs taking an hour, but it might be better to have 4 lots of 15-minute SMRs planned over a series of two weeks to a month for these patients. And make sure that when you finish the review, you summarise what's the next steps are to be, and make sure that you're the last person to leave the call to make sure all their questions have been answered. So in terms of cardiovascular patients, the priorities for these SMRs are to prevent harm. So looking at immediate safety, so what can we do straight away for these patients? And what can we do over the longer term in terms of optimising the medicines and preventing their risk of a heart attack or a stroke or a heart failure admission? Making sure we monitor these high-risk medicines, make sure we reduce the high-risk conditions progressing to a hospital admission, And it's also just to remember it's not a one-off review, it's an ongoing service with regular reviews and follow-ups. And we need to make sure that at each review we're considering any adverse effects for the patient and making sure they're tolerating everything that we're doing with them. So in cardiovascular disease, there are often lots of different comorbidities to consider. So a hypertensive patient may also have diabetes, may also have atrial fibrillation, may also have kidney disease. So these are all other things to consider in our therapeutic reviews, structured medication reviews. And talking today about heart failure and hypertension, these are often very commonly linked. So they will go hand in hand, really. So I'm going to talk about hypertension today. Recognising and treating hypertension will obviously reduce a patient's risk of having an MI or stroke, and also co-mortalities. But today I'm going to talk about two cases and concentrate on the effects of ethnicity on hypertension, and also the how to treat a patient after they've had an MI. So this is patient case 1. He's an elderly gentleman, and he was discovered for an SMR because when doing the frailty search or multiple medicine search, he came up as a high-risk patient. So he's 82 years old, his ethnicity is Black Caribbean, and he's a known hypertensive, but he's not being managed to target. His last blood pressure reading was 165/96. So he was started on amlodipine, and this was increased to 10 milligrams a month ago. He also takes lots of medicines: diclofenac for joint pain, allopurinol for gout, aspirin 75, simvastatin 40, calcium and vitamin D, alendronate 70 milligrams weekly for his bones, omeprazole 20 milligrams daily, atenolol and bendofluozide. So he takes lots of medicines. And if he was in hospital, he probably would have been reviewed on a ward round while he was asleep, and most of these stopped. But it's very different in primary care, and it's important to involve the patient in these decisions that we're making and make sure we review it regularly. So today his blood pressure is 158/94, his heart rate is 70, it's regular, but of concern is his creatinine clearance, it's 30, so he's got moderate to severe renal impairment. His sodium is 137, so it's heading towards the low end, and his potassium is 4. He has severe frailty, so he's at risk of falls. And his Q risk is 33.9%, so he is at very high risk of having an MI or a stroke in the next 10 years. So what shall we do? So when you have a patient like this who's very complex, before you bring them in for the SMR, it would be really helpful to have a plan of what you might suggest to this patient. And obviously this plan may change according to what the patient says. But Helen and I, when we've done our SMRs, we've looked at red category are things that we could stop for the patient safety elements. Amber priorities are things that we should be monitoring over the next few months. And green are things that we are changing for therapeutic benefit and medicines optimization. So for this patient, we need to look at his non-steroidals, talk about his pain, can we offer an alternative such as paracetamol for his pain relief. I think we all know why non-steroidals aren't a good idea in this patient. Review his gout medication and when did he last have a flare-up of gout, and who's managing his gout. With his renal impairment, we should be reducing the dose of allopurinol, and it should be 50 milligrams a day, but it would have to be 100 milligrams every other day because that's not available. We need to look at the diuretics. So is the diuretic exacerbating any gout symptoms? Can we change his statin to atorvastatin 20, which is recommended now for primary prevention, but also recommended by NICE in patients with kidney disease? Is there anything that we can do to help control his blood pressure? Can we add in any medication, or can we up-titrate his current medication? And is there anything else we need to know? So do we need to know his lipid levels, his blood sugars, keep an eye on his urine usines, and do we need to check for any postural drops, so standing and sitting blood pressures? Is there anything that we can stop? So can we stop the aspirin? This may exacerbate gout, but also it's no longer indicated in primary prevention. This was probably started historically when his hypertension was first diagnosed. Can we stop his PPI if we're stopping his non-steroidals? And can we look at his atenolol? Should he be on this medicine? It's recommended now at step 4, but is he taking it for something else? Is he taking it for atrial fibrillation? Is he taking it for angina? Can we review his alendronate, his renal impairment? It's not going to be effective. And can we also stop his thiazide? Because it will not be effective in low renal impairment. But what does the patient want? What are the patient's priorities? And how can we make him safe immediately, but also in the longer term, how can we make his medicines more effective? So this is a really great flowchart from the NICE guidance that is really useful in recommendations now for drug treatment of hypertension. The only thing that I don't like about it is they spelt diuretic wrong, and once you see that, it will annoy you, but it's really useful. But for a Black Caribbean or African Caribbean patient, we should be using a calcium channel blocker first line, and then adding in an ACE or an ARB or a thiazide-like diuretic. But as we know, this patient may not be suitable for a thiazide diuretic with their gout history. And then the step 4 is adding in spironolactone or an alpha blocker or a beta blocker. So in these patients, unfortunately, there's an increased prevalence of hypertension in patients of this ethnic origin, and there's also a higher incidence of stroke as a result of this, but it can happen earlier than we normally see, so we can see it in patients in their 30s and 40s. And it is thought that they respond less well to renin-angiotensin system blockers because of low renin levels. And in the ALLHAT study in 2006, there was actually an increased incidence of angioedema with ACE inhibitors in these patients, and there was slightly less of an incidence in patients on ARBs. So they often need multiple drug treatments to control their blood pressure. So in the SMR, what should we do? Is there anything new that we need to add? Consider the patient's preference on their risk and benefits of treatment. We definitely need to try and reduce the blood pressure to reduce the cardiovascular risk. And inform the patient of monitoring requires and potential side effects and when we'll see them again. We need to try and stop the non-steroidals, and we also need to think about what can we make safe in this patient's renal impairment, and think about any risk factors for adverse reactions. So in this patient, there is this risk of angioedema with the ACE inhibitor. So we're going to try an ARB, we're going to try candesartan. And what we'll do is we'll see if it's making an effect in the next month. So is it reducing blood pressure? Is it causing the renal function to go off? And we'll keep a close eye on this. And we'll also talk to the patient about reviewing the atenolol. What's it for? How long have we been taking it for? Is it something that we can increase the dose of according to the blood pressure and the heart rate? Or do we need to gradually withdraw it? We can't stop it because if we stop it straight away, then we risk precipitating an MI or any of the other symptoms. We could also consider indapamide. At the lower doses of indapamide, it's more of a vasodilator than a diuretic, so that's something to think about, but also it may affect his gout. But also the patient's main concern may actually just be the pain relief because that's what the patient can feel. So in the 1 month review, he's on amlodipine 10 and candesartan 8. He's going to try paracetamol for his pain relief. And he's going to try taking the allopurinol every other day with his renal impairment. We're going to keep the atenolol going, but we're going to review it, and we're going to change his statin. His blood pressures come now 154/94. But what should his blood pressure be? So again, looking at this table, the blood pressure targets for patients who are aged over 80, the clinic blood pressure should be below 150/90. And if they're taking their blood pressures at home, it should be less than 145/85. But we do need to consider the risk in this patient of postural hypotension and the risk of his frailty. So at the month review, he's taking amlodipine 10, candesartan 8 and atenolol 25. His blood pressure has come down slightly and his heart rate is 65 and it's regular. There's no change to his UNEs, so we're going to increase his candesartan dose, as long as he's happy taking it, to 16 milligrams daily and review it in a month. So we're aiming for a clinic blood pressure of 150/90 and a home blood pressure of 145/85. But we do have to be very careful with these patients that we don't increase their risk of having a fall by doing this. But we do want to reduce their risk of having a stroke or an MI. We also want to make a plan for reviewing the atenolol. We don't want to make the patient too bradycardic, but we also want to review if it really is necessary. We want to check the patient's happy with their pain relief, and we want to talk about adherence. Is the patient actually taking all of the medicines as prescribed? In hypertension, it's really important to address adherence when you're looking to review your patients. Far too often we add in more medicines, or we increase doses and the patient isn't actually taking them as we hoped they were taking them. So there can be mistakes that are made in prescribing. It can be forgetfulness from the patient side. It can be not understanding why they need the medicines or how to take them, or because they have side effects they haven't discussed with anybody before, and it's because they have their own beliefs about medicines and their benefits. So the next patient I wanted to highlight to you is a patient who has been recently discharged from hospital. He's a white male, age 56, and he was recently discharged from hospital following a non-ST elevation MI, and he had a drug-eluting stent to his left main stem. So this is supplying his left ventricle. So it's quite a serious MI. He was taking no medication before, and he's being sent home with aspirin, ticagrelor, ramipril, bisoprolol, atorvastatin, omeprazole, and GTN spray. His ejection fraction is 60%, so he's doing well, and he's asking for a repeat prescription at the GP practice. His blood pressure is 158/96. So what we should be asking is, what else do we need to know? Why wasn't this high blood pressure picked up before he had his MI? Does he need a structured medication review? How should we manage his hypertension now? How often should we be seeing this patient? We need to make sure that the practice knows about this patient and is on the hypertension and CHD register. And we also need to discuss cardiac rehab with the patient, because that's a very good way of the patient learning about lifestyle, medicines, and how to cope following his MI. So for our SMR, it would be really good to address his lifestyle. So when he's in hospital, he's probably been told all about an MI, all about his medicines. He's been given a lot of information. He possibly hasn't registered it all because he's still coping with the fact that he just had an MI. So our aim when we see him is to talk about what's happened, talk about his lifestyle, talk about medicines. So one of the things that we can target with this patient is the fact that he smokes 20 a day, and that's a big risk factor for cardiovascular disease. In the first year post-MI, it's a very high risk period, so we need to be trying to make sure that we do as much as we can to help this patient in the first year. He travels a lot with work, so eats out a lot, so looking at his diet, he doesn't really exercise much, he hasn't got time, he's got a very busy and stressful job. He's a little overweight and he drinks most evenings, but more at the weekends. So what we can do is agree with the patient 1 or 2 things that they can do to suit their daily lifestyle, set them some goals, give them encouragement and signpost support services, but be realistic. What can he actually achieve in the next month when he's just had an MI? Lifestyle has a big effect on hypertension and reducing your blood pressure. So studies have shown that if you reduce some weight, if you eat healthily, if you reduce sodium, if you try and are active most days if you can, and if you reduce consumption of alcohol, you can reduce systolic blood pressure. And in the NICE guidelines that came out last year, we should be treating any patient whose blood pressure is 150/95, or if they have high cardiovascular risk. And this patient, unfortunately, has a high blood pressure that already has target organ damage. He's already had an MI. So this patient is just over 55. So ideally, his first line treatment would have been a calcium channel blocker, and then adding in the ACE or the thiazide-like diuretic. However, he's just had an MI, so it's really important that we get his ACE inhibitor and his beta blocker up titrated as high as we can to reduce his risk of having a further MI. So what we're going to do is increase the dose if his UNEs and blood pressure allows, and check his heart rate and his blood pressure and keep increasing his beta blocker. The plan for him would be to add in amlodipine at a later stage if we can't reduce his blood pressure with his secondary prevention medicines. We also need to think about what we need to keep an eye on and what side effects we need to talk about with this patient. And he might not be keen to start more medicines. He's not taken medicines before and suddenly has 8 medicines to take. And he might actually not want to pay the prescription charge every time. This is something patients often complain about after an MI. I can't afford all these medicines. So it's just something to consider when you talk to the patient. And we should really be trying to see him in a month's time, checking his blood pressure, checking his lifestyle, checking how he's doing and what support he has available. So this just gives you a reminder of how to monitor antihypertensive. So ACE inhibitors, we're monitoring blood pressure, creatinine, potassium and sodium. Calcium channel blockers, blood pressure, heart rate. Diuretics, blood pressure, creatinine, electrolytes. Uric acid if someone has gout. And beta blockers, blood pressure and heart rate. So reducing his cardiovascular risk. So we want to make sure his blood pressure is controlled, so with lifestyle and medication, increasing his ramipril and his bisoprolol dose. We need to talk to him about his antiplatelets. So these antiplatelets are started after the MI to protect the stent that's been fitted in his artery. And at a year, we should be reviewing them to make sure that we're not going to increase the risk of bleeding. So if he's on ticagrelor, he'll be on ticagrelor 90 milligrams twice a day. And after a year, this dose can be reduced to 60 milligrams twice a day if they are very high risk. And there's a list there, and all the cardiologists will have told you to reduce the dose, or it can be stopped after a year. There's also a consideration about cholesterol. So if his torvastatin 80 is not reducing his cholesterol to 40% less than it was when it was started, we can add in ezetimibe to try and get the cholesterol down even further. We should be checking these patients every 2 weeks to every month until we get the blood pressure correct. Looking out for side effects and checking their adherence and checking for any side effects or any signs that the blood pressure is affecting the patient. So at 1 month, his blood pressure is really improved and he stopped smoking. So we need to give him lots of encouragement and support there because he's already reduced his cardiovascular risk greatly. And he's thinking about walking more. But we need to also ask him, has he had any chest pain? Has he needed to use his GTN spray? Does he know how to use it? And does he carry it with him? Because lots of patients don't know that this is what they have to do. His renal function is normal, so we can increase the ACE inhibitor and we can check him again in a month, aiming for this clinic blood pressure of 140/90 or his home blood pressure of 145/85. And we'll try and increase his bisoprolol depending on his heart rate and his blood pressure. So just for you, if you need to know more information about hypertension and what is available for you and also for your patients, there are some resources there. And in South East London, we have a revised blood pressure management traffic light poster, which once you've checked someone's blood pressure, it tells you if their systolic is a certain value, their diastolic is a certain value, what to do. There's also blood pressure management guidance and medicines management guidance that is just under consultation at the moment. And we also have a self-monitoring patient diary for blood pressure readings and a poster for patients as to how to take their blood pressures at home, because we are very aware this is becoming much more common now. Thank you.
Thanks, Rachel. I've got a question from you, from the audience. Post-MI, is one risk factor more important to control than another? For example, is hypertension more important than cholesterol control if you have to prioritise your time in the clinic?
Helen, do you want to answer that one?
Well, really, we need to be addressing global risk. So we have tended to think of things in isolation, I guess, in the past. You know, patients coming for their blood pressure, patients coming for their lipids, patients coming for their blood sugar because they're diabetic. We do need to think about global risk, but I guess in some ways you can say it's a marathon, not a sprint. So we're unlikely to want to make changes on both blood pressure and lipid management in the same patient at the same sitting. So, you know, if you're addressing hypertension in this clinic, you maybe will think about lipids in the next, depending on what impact the intervention you've made. I think we have to recognise if we change 4 or 5 medicines all at the same time, because we're really chasing targets aggressively, then we won't know what side effects are associated with which drug when the patient comes back complaining. So it's yeah, we need to address them all, but we just need to do it in a phased approach, like Rachel said. You know, a structured medication review in total is meant to take an hour, but you don't have to do it an hour in one sitting. You can do 4 15-minute slots, for example, and that's more realistic, where you've got multiple interventions to make to really track the impact of those interventions. I think we've got some more questions. We've seen an increase of twice daily dosing of ACE for post-MI patients from hospital. The rationale given was to reduce symptomatic hypertension, especially when a higher dose is needed, either, for example, ramipril 10. Any comment on that, Rachel?
Yes, that's more of a heart failure dose, isn't it, Helen? That's what you might do. I think
even in the post-MI studies, ramipril was used twice daily. That was the design of the studies. So the AIR study was BD ramipril, and the heart failure dose is BD ramipril. It's only a licensed OD in hypertension, but I have a pretty low threshold for switching to once daily if there's an adherence issue, and if they're not taking other evening-based drugs, I guess.
Thank you.
A question around ticagrelor. Is there evidence for using ticagrelor beyond 3 years? If not, can patients on ticagrelor as DAPT for more than 3 years be stopped, or needs further discussion with cardiology?
Yeah, I would always suggest discussing it with cardiology if you want to stop it. Would you agree, Helen?
Yeah, so the license for ticagrelor is 90 twice daily for a year, and then 60 twice daily for up to 3 more years. Now, really, it should tell you on the discharge summary if it's to stop at, you know, that it's to stop at 3 years. But if it doesn't tell you the duration, then it is worth an advice and guidance. It doesn't need a referral to cardiology. I would suggest advice and guidance to see what their recommendation is. I mean, it's going to get much more complicated because we always have other options like the rivaroxaban, low-dose rivaroxaban now for coronary artery disease and peripheral arterial disease in combination with aspirin for a similar patient cohort. So we would be looking to cardiology to be a bit more explicit about what they want at the end of the first year of treatment. Another question here. In the case of the over 8-year-olds, we would increase ARB as systolic blood pressure is 152. If on follow-up the BP is less than 150, we could stop the atenolol. I'm conscious that in other SMR training we've been advised to treat the patient, not necessarily the number. Also, the NICE older people guidance indicates that the majority of specific disease guidelines are not a priority in frailty and polypharmacy. It is slightly different with hypertension, because I was looking at the QOF to see, because I know they've changed some of the indicators around frailty, but they haven't changed the indicators for hypertension. And that's probably because we have very robust data in older people in hypertension. So that, you know, normally we don't have any data in older people, and we just assume that what we do for a cohort of people in studies between the age of 50 and 70, we do ad infinitum. But there was a specific study in older people looking at hypertension, and the HIVET study, and that was looking at the over 80s and treating to this 150/90 target, and showed such substantial benefits that we really should be aiming to treat unless there's a really valid reason not to, like evidence of postural hypotension, patients complaining of dizziness and thinking they're going to fall over. So it's unique, really, hypertension, in having very robust data in the over 80s, reducing stroke, reducing heart failure. You know, the impact, the evidence is very strong. So in contrast to most other conditions, we should be treating to target, unless you think there's some life, you know, unless the prognosis is very poor, you know, patient's already moribund and has very, very poor quality of life. Because you've got to think, if you don't treat these patients, their risk is they'll have a stroke, and quality of life will deteriorate much, much more. What about social prescribers being involved in the lifestyle management? Any comments on that? And maybe even people on the call, you know, listening in might have ideas about how much the social prescribers are used. As fact, someone said here, yes, in some cases I routinely refer to social prescribers unless the patient objects. But yes, you have to start the conversation, otherwise they'll never get to the social prescribers. There's quite a few comments about timing. One of my doctors says no more than 20 minutes, but again, if you make it into 3 or 4 different visits, then it's pretty much routine practice, isn't it? And they add up to the SMR. I don't know how, at the moment, obviously we don't quite know what the DES is going to look like, and what you're going to have to do to meet the requirements of it. Does QRISK also apply to over 80s and 90s? Some centres of excellence, does that mean, COE? So no evidence for statins in the elderly population. I've just been looking at this actually. Oh, care of the elderly consultants. No, I knew what. I thought it might mean Church of England, but I wondered what the context would be. So QRISK goes up to the age of 84 and is accurate up to the age of 84. There is evidence for statins. The NICE guidance recommends statins in the over 85s on the basis that it reduces non-fatal infarction in the clinical studies. And clearly, if the clinical studies were big enough, it would also show a reduction in mortality. So there is evidence for statins in the over 80s. In fact, there was something very recently published, I'll have to go back and search for it, about the evidence for statins in the elderly being there. I'm sure there was a comment in the PJ about it. Question for you, Rachel. Advice on using CCB to treat hypertension in patients who've had an ACS.
Yeah, so in someone who's had an ACS, the main priority would be to increase their secondary prevention medication. So it would be your ACE inhibitor, your beta blocker, and then add in a calcium channel blocker if necessary, but only if you can't get the blood pressure to target with those medicines. That would be the main priority, especially in the first year.
Can too tight control of lipids, I think it means, it says statins, cause problems? There has been some studies that have looked at how low patients have got. I mean, you know, if you look at, say, the statin studies like the heart protection study or treat to new targets, they've looked at what's happened in people who've had very, very low cholesterol levels as a result of statins. And they haven't found an increased risk of events in that cohort. You're born with an LDL level of something like 0.6. So the theory is that until we get below 0.6, LDL, which we very, very, very rarely see, then we're really not doing any harm with statins. I don't think I've ever seen anyone with an LDL of 0.6 in their 50s and 60s and 70s with on a statin. I'll share the link to the most recent analysis of statins in the elderly for you all. A question about beta blockers. I read guidelines which states that you need to review beta blockers 1 year post-MI and stop if no signs of heart failure. I was a bit alarmed by this. What would you advise?
Yes, this is potentially going to be in the new ACS guidance that's coming out at the end of this year. Unfortunately, the evidence for beta blockers beyond 1 year is they considered in NICE lacking. However, you need to be really careful stopping beta blockers. They need to be stopped gradually and tapered down over time. But many patients post-MI do have other issues like the heart failure, like the atrial fibrillation to consider. So it's not straightforward stopping beta blockers. And
also they might have underlying ischemia, which the beta blockers are controlling. So you might see chest pain occurring as you stop the beta blocker. So it isn't easy. But the new ACS guidance looked like it might recommend withdrawal at 1 year post-MI. So what is the risk of stroke in over 80s if not at target blood pressure? Can we give our patients numbers to our patients in clinic? Personally, I found it easier to start medication before discharge from hospital than in general practice. So it is hard to initiate any of these meds really in general practice, but it's also probably also not necessarily appropriate in hospitals. Having worked in hospital for many years, and Rachel, she'll probably have seen the doctors go around the end of the bed and go, you've got high blood pressure, I'll start you on amlodipine. Your next day review, oh, it's still high, I'll increase it to 10. Oh, it's still high, I'll add in an ACE inhibitor. And you know, if they are very aggressive, but then by the time you see these patients, their blood pressure is about 90 systolic, and they're really running into problems. So patients are not in hospital long enough to optimize antihypertensives. It takes 2 to 4 weeks for the antihypertensives to have their full effect. So while hospital might be able to do one intervention for blood pressure, they can't optimize in hospital. And also, you know, when you're lying in a hospital bed, your blood pressure might not be reflective of what normality is for you. So we may end up undertreating effectively because people aren't doing any physical activity. So it is a pain, but it's certainly a primary care issue, managing high blood pressure, rather than a secondary care issue. And I think someone's put a comment that with appropriate follow-up, antihypertensives can be managed in primary care. And we've been doing across South East London the integrated pharmacy and meds optimisation project, looking at exactly how specialist pharmacists from the hospital can support general practice pharmacists with difficult to manage hypertension, so it can be managed within the practice. And also an element thinking about how we link in our community pharmacists for supporting the monitoring of patients. Another question for you, Rachel. And then I'm going to go on to my talk, because otherwise we might run out of time, and then we can revisit questions toward the end. Another question about second prevention. If a patient is on a DOAC, should we stop antiplatelet therapy?
Oh, excellent.
Nice easy question for you to answer. No controversies there at all.
There are lots and lots of factors at play here. So so if the DOAC is for atrial fibrillation, they sometimes do keep the DOAC going with antiplatelet therapy, post-stenting. It does very much depend on a case-by-case basis, but you always review after a year. Do not keep the combination going for longer than a year if you can. And it needs to be discussed with whoever started the DOAC or the antiplatelet first, just to make sure there's nothing else we've overlooked.
So let's move on to heart failure. Rachel, are you going to manage the slides for me?
I am, and I'm going to turn off my camera. Thank you.
Thanks, Rachel. Right, my slides aren't moving at the moment.
There you go.
There we go. So heart failure. Next slide, Rachel. So there are a few challenges in heart failure. One that we're not going to focus on today is diagnosis. So finding people who have heart failure that haven't currently got a formal diagnosis, determining the type of heart failure and coding these patients correctly. And those latter two are really important because they affect the treatment decisions you make. And therefore, it's really important that you understand the diagnosis for heart failure and the type of heart failure the patient has. In terms of treatment, we need to manage the patient's symptoms, make sure in primary care that the patients had first-line therapies initiated and that they're optimised. Think about lifestyle and cardiovascular risk factors that are exactly the same as for patients with hypertension or post-MI, and then think about which patients would need medications beyond those first-line therapies. So next slide. Rachel, there we go. So our patient today is a patient by the name of RJ. He's a 73-year-old male with known heart failure. He's been called for an SMR due to having 10 plus medications. He's generally well in himself, but he does complain at the clinic visit that he gets shortness of breath on exertion and some swelling of the ankles. He denies having any chest pain. His past medical history is asthma, heart failure in 2015, hypertension from 1994, back pain in 2012, angina from 2001, and depression since 2009. So he's on a nice cocktail of medications. He's on furosemide 40, ramipril, 2.5 milligram daily, bisoprolol 1.25 milligram daily, is on aspirin 75 and atorvastatin 20, is on naproxen 500 milligram twice daily, amlodipine 10 milligram daily, isosorbide mononitrate 60 milligram daily, Symbicort and butylin and montelukast for his respiratory disease, sertraline, and he has a GTN spray. So quite a mixture of medication. Next slide. So when you're looking at patients with heart failure, you're going to need to assess their functional status and their clinical status every time you see them. You're going to have to build this slide for me, Rachel. Sorry, next click. So symptoms wise, the things that we look at are breathlessness, ankle or leg swelling, and that can come right up the leg to the hips. Abdominal in very severe cases, abdominal discomfort, and actually there seems to be a difference in symptoms between our Caucasian population and our Black African Caribbean population. So the white population get a lot of ankle swelling, which can be present in our Black African and Caribbean patients, but more commonly we found abdominal discomfort. So, the men would say, oh, I can't do my belt up like I normally do, because the fluid is accumulating there rather than in the ankle. And tiredness and lethargy. So they're very non-specific symptoms and easy to get mixed up with other common conditions. Clickers on again twice, I think, Rachel. Can you move the slides on, Rachel? Or are they frozen?
Have they gone too far?
No, it's not moved on our screen, on my screen. Has it moved on yours? I'm just wondering if I can open the slides, although whether I've got the most recent set is anyone's guess. Well, mine hasn't changed. Let me see if I can open them at my end and share them, then we won't have the time delays. Hold your horses a second, everyone. I'm just going to open the slide set on my system. That's better. Can you all see the slide now? With the ankle, is that working?
Yes.
Great. So I'll control them at my end now. So the other things we need to think about are signs. So respiratory crackles, rapid changes in body weight, because that's fluid, it's not changes in fat, obviously. Raised jugular venous pressure, reduced exercise tolerance. So measuring how tired, how limited people are by looking at how far they can walk, can they climb stairs, etc. Palpating to see if they've got hepatomegaly, and obviously measuring renal dysfunction. And the two types of heart failure that patients can have, they're mutually exclusive. So you either have heart failure with reduced ejection fraction, which we used to call left ventricular systolic dysfunction. The BNP will be raised, and the echo will show a reduced left ventricular ejection fraction. And that's our traditional heart failure, where we have a lot of prognostic medications. Then there's heart failure with preserved ejection fraction. The signs and the symptoms look like heart failure. The PNP is likely to be raised, but the echo shows a normal left ventricular function. So the ejection fraction is greater than 40%. And usually it's problems with filling of the ventricle, so diastolic dysfunction, the heart isn't relaxing properly. But there can be all sorts of things like valvular dysfunction, which may require surgery. So there's no prognostic medication that we have for HFpEF, heart failure with preserved ejection fraction. And that's why it's so important patients are coded properly. In HFrEF, heart failure with reduced ejection fraction, we know we have drugs like ACE inhibitors, beta blockers, aldosterone antagonists that really improve outcome. And we really need to identify that cohort of patients so that we can treat them effectively. So for our patient RJ, we need to know what the echo shows so that we know if he has HFrEF, heart failure with reduced ejection fraction, or HFpEF, heart failure with preserved ejection fraction, and his ejection fraction is 32%. So he has left ventricular systolic dysfunction, our classical heart failure. His heart ventricle isn't moving correctly, He's not particularly compliant in terms of his repeatedly DNA'd his heart failure clinics, and he's not been seen by the heart failure team for at least 2 years. And he's also previously refused angiography, but he doesn't report any chest pain. So his blood pressure is 105/62. Renal function, he's got stage 3 CKD with an EGFR of 56, creatinine is 132, urea is 54, and his potassium is 4.2. LFTs are normal, and his cholesterol is 4.4. So in terms of priorities, we need to think, well, what should we be thinking about doing for him? And from a patient perspective, the first thing I would be worrying about is managing his symptoms. So he feels better on a day-to-day basis, thinking about his long-term prognosis. That might be over the course of a number of visits, seeing if he needs investigations and management for angina. He's denying any chest pain at the moment, so it's not a major priority, and also making sure we've got all the right second prevention medication in place. So in terms of heart failure in primary care, for heart failure with preserved ejection fraction, so not what he has, it's really about managing all the comorbidities as aggressively as we can and keeping him as symptom-free as possible. But in heart failure with reduced ejection fraction, so the ejection fraction here was 32%, so he has this form of heart failure. The first steps are ACE inhibitor and beta blocker, and a mineralocorticoid receptor antagonist if the symptoms continue. And this is what I consider the primary care part of the pathway. The patients, if you've done all this and the patient's still symptomatic, then it's time for specialist reassessment. So early symptom management will be increasing the frusemide. You could increase him from 40 to 80 a day, or you could give as a single dose, or give him 40 twice a day, as long as the second dose is early afternoon, for a few days to reduce his symptoms. You could look at reviewing the naproxen, because that's going to make things worse, both in terms of sodium and water retention, but also in terms of potentially reducing his renal function. And assess his dietary salt intake. And at this point, I'd be thinking about all his other lifestyle issues. And then NICE guidance would say if he's still symptomatic, you could consider an aldosterone antagonist. But I would suggest that there's more we can do with his existing meds before we add another one in. Do that. So I've said that I think the role of primary care in heart failure is to focus on the first line drugs, which are essentially the beta blockers and ACE/ARB with beta blocker. And you can see that of all the interventions in heart failure, which reduce mortality at 2 years, these two have the biggest impact on outcome for patients. So there's a lot we can do in primary care to really improve outcomes for patients. What the cardiologists do is just shining it up a bit. If we've got them on an ACE and beta blocker, we've done most of the job already. And it's not just initiating ACE and beta blocker, it's also optimizing the drug. So the dose, so that we get them to ideally the target dose that was used in the studies, but if they can't get to that, the maximum tolerated dose that the patient can take. There are obviously some things that will limit our ability to up titrate ACE and beta blocker. So for both of them, the patient may get symptomatic hypotension. Even someone with a history of hypertension in the setting of a poor cardiac output due to heart failure, they can start to show, become symptomatic with a low blood pressure. For ACE inhibitors, we may see worsening renal function, but we would accept creatinines up to 200 before we panic about renal dysfunction, because the benefits of these drugs are so substantial. Patients might get dizzy and lightheaded and have postural hypotension and feel that they may fall over, and obviously we need to address that, and it might be a limitation to the overall dose. And obviously they might get a persistent dry cough related to ACE, but the simple solution to that is to use an ARB that's licensed for heart failure, such as candesartan, valsartan, or high dose losartan. For beta blockers, you have the same problem of symptomatic hypertension. You also have the issue of bradycardia, so a slow heart rate. And I've had a patient who could only tolerate like 1.25 milligrams of bisoprolol before the heart rate dropped below 50. So every time we tried to push it up, he wouldn't tolerate it. So we had to accept that the maximum tolerated dose of beta blocker for him was 1.25 of bisoprolol. Patients who have airways disease, reversible airways disease, may deteriorate. We certainly wouldn't withhold beta blockers in patients who had asthma if they were very brittle. We might supervise the first few hours after the dose, and we've even brought someone into hospital, but it shouldn't be used as a contraindication in the heart failure setting. Clearly in other settings you would avoid beta blockers wherever possible. Tiredness and fatigue, which is difficult to separate from the heart failure tiredness itself. Weight gain due to fluid congestion and also erectile dysfunction are all things that can prevent us optimizing beta blockers in practice. Just to give you an idea of where we are at the moment in England with heart failure, if we look at our heart failure register, there's 554,455 patients on the heart failure register in England. Of those, only 30% are on an ACE and only 24% on a beta blocker. So there is work to be done to ensure patients are diagnosed correctly, are coded correctly, and are offered ACE and beta blocker, because probably 50 to 60% of heart failure is heart failure due to reduced ejection fraction. And all of those patients should be on ACE or beta blocker, and currently probably only half of them are. If we go back to our patient and his structured medication review, we've got him on a whole load of medicines there. So let's have a think about what we might want to address. And again, this wouldn't be all in one sitting. We know that we need to manage his symptoms by up and down titrating his furosemide. In the weather you've got down in London at the moment, you know, patients aren't going to need much diuretic at the moment because they're going to be sweating it all off. But in the middle of winter, they're likely to need more, and that's why it needs to be titrated, depending. It's weather dependent as well as disease dependent. Two green interventions there, and they're around these drugs that we know improve prognosis. So ramipril and bisoprolol, currently only at low dose. It may be that there are reasons why they're at low dose that prevent us from optimizing them. So we need to check blood pressure, we need to check renal function, we need to check heart rate with bisoprolol, and also you might want to keep an eye on his asthma control if you're, well, you certainly would if you're dose titrating these drugs. So those are our core drugs for primary care to optimise around heart failure. Aspirin he's going to need to keep because he's got a history of angina. He's only on a TOR for 20. Now, ideally, he should be on a TOR for 80. So I'd be looking to see why he isn't on the optimum dose for secondary prevention. I mean, if we're going to give people these drugs, we should give them the minimum effective dose, which in secondary prevention is 80 milligrams, reducing to 40 if they don't tolerate it. So bearing in mind he's been on 20 for a while, you might be nice to him and say, can we increase it to 40 and see how he gets on before going to 80 if he tolerates it. But that's a sort of amber intervention. Not as urgent as the heart failure interventions, but something to do in the future. Obviously trying to stop the non-steroidal if we can. But there are some patients with heart failure who without non-steroidals can't move due to back pain, you know, arthritic pain, and therefore it has to be a compromise with the patient to try simple analgesics. But if they leave him unable to go and do his daily activities, then we might have to consider non-steroidals. Now he's on amlodipine 10. Now this could be for angina or it could be for hypertension, but it certainly isn't for heart failure. So if it's for hypertension, we might be able to withdraw it when we optimise the ACE and beta blocker, because actually having the amlodipine there might you know, lower his blood pressure to the point where we can't optimise the ACE and the beta blocker. If we get the beta blocker up, then that will act as an anti-anginal if that's how why his amlodipine was started in the first place. The isotonic mononitrate again, we could see whether he really, not at this point, but at some point in the future, does he need this once the beta blocker's optimized? Is that sufficient anti-anginal therapy for him? And that will be one less drug. Clearly, you need to review his asthma control, looking at the use of terbutaline, the combination of Symbicort and Montelukast, and see if there's anything there that needs amending. And the asthma, I guess, would be a concern to many of you in terms of up-titrating the beta blocker. But remembering, of course, that bisoprolol is a cardioselective agent and has minimal effects on the receptors, the beta-2 receptors in the lungs. Sertraline, again, I'd want to know how long you've been on it. Could we think about cessation? I find patients get started on SSRIs and never get reviewed in line with NICE recommendations. So it's a potential to withdraw that drug, which would reduce the pill burden. And look at his GTN use. He says he doesn't have chest pain, but clearly if he's using GTN, it might be happening more frequently than he's sort of noted. But presumably he's using very little GTN, but he should still have it available. So there's a lot we can review for this patient. As I said, we're not going to do it all in one sitting. And I guess the difficult bit that we can't capture in a teaching session is the bit about, well, what's the response of the patient to these discussions? Which things are they willing to relinquish, and which things are they willing to allow you to increase? And it may be you even in the first sitting don't get any changes made, because it's all about getting the patient on board and discussing the options, for example. And then the other piece, which we haven't much time to talk about, is identifying and addressing any adherence issues that may be evident when you start to have that face-to-face conversation, or even video consultation or phone conversation. Once you've done all that, then is the time to think about adding in an aldosterone antagonist if he remains symptomatic. And that's probably the final step really in management in primary care, bearing in mind, of course, that renal function and potassium particular issues when you add in aldosterone antagonists on top of the ACE inhibitor that he will already be on. So really in primary care, we're going to be looking at ensuring patients have a robust heart failure diagnosis, and if they don't, getting them BMP checks and echoes, making sure they're coded so they fit into the right cohort of patients. You'll have to ignore those codes that are on there because they're the old EMIS codes and we need to use the SNOMED codes now, so erase those from your memory and I'll delete them before we share the slides. Making sure we manage the patient's symptoms by increasing or reducing diuretics, optimizing those first-line therapies and addressing any adherence issues. If the patients are on top dose of those first-line therapies, then they remain symptomatic, ensuring they get next referral on really for specialist intervention. And we should be reviewing these patients every 6 months according to NICE, or annually according to QOF. So this is now in QOF to annually review these patients, and that's the summary of the points you should be looking at. So the clinical assessment, functional capacity, fluid status, cardiac rhythm, cognitive status and nutritional status, a review of medication and an assessment of renal function. So that's a very brief overview of the sorts of interventions you might come up against or need to be making in a patient with heart failure. They do tend to be more complex than many hypertension patients in that their renal function is often poor, their blood pressure is often low, and they're often symptomatic. So they are quite tricky to do meds reviews on. But I would also recommend you link with your local community heart failure nurse. So in South East London, most of the boroughs will have community-based heart failure nurses who can help with these more complex patients. And I'm going to stop there and see whether we've had a load of questions.
Thanks, Helen. Sorry about the mishap. We have got questions, but we've only got 1 minute left. So shall we go through the questions, or People have
Let's
to
do
go.
1 or 2 questions and then we'll do the rest of as FAQs, I think. Is that right? Have we got
That's
time?
right. So I think that's right. So I think people may have to leave at 2 o'clock, but we can keep going from our perspective. And we just summarise the questions and we can put that in the chat box and people will see that on the recording.
Okay. So the most popular one at the moment is Helen. When do we stop furosemide or bumetanide? Some patients are left on it for a long time with no symptoms.
Well, normally what we try to identify is what the patient's what we call dry weight is. And then once they achieve that dry weight, withdraw the diuretic and see if it creeps back up again. I mean, ultimately what we'd really like is patients to manage their own diuresis. So many heart failure patients are taught to get up in the morning and after they've been to the toilet, but before they get dressed, to weigh themselves. And then if the weight goes up by more than 2 or 3 pounds in over the next 2 or 3 days, then they're to increase their diuresis. And if it goes down by 2 or 3 pounds, they're to reduce the diuresis to maintain them as much as possible within their normal dry weight. So there's no harm in trying to withdraw the diuresis, but some patients will require long-term low-dose diuretic just to maintain, to assist them really in clearing fluid in chronic heart failure. But you need to have a plan in place. So, you know, if you take the diuretic away, the patient needs to be able to weigh themselves daily and tell you if they've suddenly put on a kilo over 3 days, because clearly that's all fluid, and therefore they will need to restart the diuretic.
Thank you. And what do you do if the heart rate goes below 50 beats per minute? When do you reduce the beta blocker, and how many times should if it goes below 50, would you reduce? As sometimes it's only once in a while. So that's kind of, when do you review the beta blocker, Helen?
So yes, I think ideally you'd get the patient to check what their pulse rate is at home if they can when they're resting, because that would give you a better picture of how well beta block they are. And really the cardiologist would say they want the patient hovering around 50, but most GPs aren't that comfortable when it goes below 55, to be honest. So I think if they're dropping below 50 and they're in front of you in a clinic setting, then you probably want to reduce the dose by 1 increment, because think about what happens to them when they're sleeping overnight. And, you know, occasionally you get phone calls with patients going, I just checked my pulse and I've been sitting at home for a while and it's 30. And you think, yes, that's a bit low. What we're measuring in a GP practice is often not what the true resting heart rate is. So yes, if it's, I would aim to get it in the clinic setting between 50 and 55. And ideally get the patient to be able to monitor at home. You know, if they've got a home blood pressure machine, then the monitor will tell them what their pulse is. They don't have to necessarily put fingers on the pulse and feel it, because some people really struggle to do that.
Thank you. And one more, if the atorvastatin dose, would you increase it to 80 regardless of lipid profile readings?
So it's that thing about treating global cardiovascular risk. If he's got coronary disease, then the recommendation, and it's really based on the way studies were designed with statins, we didn't ever design studies that said, let's see if we can get your cholesterol to 4, half the patients, and your cholesterol to 5 and see which is better. What we did in the studies was put people on Atorva 80, Atorva 20, Simva 40 and saw what happened. Now in second prevention, we know that Atorva 80 is better than Atorva 10 because that's what the studies have shown. So we're not necessarily treating just the cholesterol, we're treating their whole global cardiovascular risk. And ideally we should do what the studies did, which is using these very high intensity, high dose statins. It does become more tricky in the older population, but he's only in his 70s, isn't he, if I remember rightly? So it wouldn't be unreasonable in him to definitely try him on 80 and see how he goes, because you can always reduce it again, but lower doses we know don't give the same effect.
Fabulous. Thank you very much, Rachel and Helen, for sharing your wisdom and knowledge about matters of the heart with us. It's really, really good to have you with us. Thank you everybody for joining. It's really good to see you all, and I hope you gained loads from this. And I found it particularly very useful that you guys have added guidelines and put it in terms of a real life case study. It's very useful. Thank you. So as mentioned earlier, this webinar will be recorded, and the link for the recording will be distributed through your borough-based medicines team to you and the other pharmacist networks. Just to let you know, we've had previous webinars which you can obtain the link for where the recording is saved with from your medicines team. And this recording will be distributed to your medicines team as well, and they will distribute to you as well. We have 2 more webinars that is going to occur. So one is on Thursday, this Thursday, the 13th of August, for structured medication review and mental health. And then next week, Wednesday, we've got structured medication review in diabetes. So please join us again. Thank you very much for joining. And if you have not received the calendar invites for the webinars that are coming up, please contact your borough-based medicine team. Thank you very much, everybody. Bye.